I'm Michael Brandt. I'm your Deputy Lab Director for Operations and Chief Operating Officer. And this afternoon, Dr. Timur Durrani is going to discuss a couple of the published papers about the coronavirus as a way to teach us how we're interpreting the science. And so this is more than what you would see on CNN, Fox News, any of the news stations that you look at. This is to focus on the research. And after we go through this, we'll open up the floor for questions, okay? And so with that,
great.
Timur.
Thanks, Michael. Thank you, everyone, for coming in and tuning in online. As Michael said, I really have two objectives for this. The first is to go through the actual published paper science. And the reason I'd like to do that is to show you the way that we in the medical world look at journal articles, interpret them, understand the pros and understand the cons. And I'll walk you through those. And then the second is to be able to answer questions. So I should preface this by saying that I am the mouthpiece for a bunch of teams that are working on addressing this in real time. And so I can tell you that there is an entire team of people, the Critical Incident Management Group, who is working on this literally day and night, churning out answers and finding out how things will work for people if they need to work from home and so forth. So that's one team that exists here. We have an entire other group that I've talked about before, which is the Environmental Health and Safety Team, which is a division here that's got over 100 people that do a variety of things, including looking at risks, health, infectious disease. And then within that, we have health services, where we have doctors and nurses, medical assistants, a variety of people who work full-time, all to try and address this. So I am just one of an entire group. If you put all of those people together, we're probably close to 200 people that have expertise in a variety of different hazard mitigation pieces. So that's the first part I wanted to go over with you. The next piece is just to recognize that, this is a big time of what I would call anxiety. And so my hope here is to provide some information. I don't think I'm going to be able to specifically reduce any anxiety. What I'd like to be able to do is provide you with the same information that I have so that you're able to make your own decisions. We're at a place where people have a lot of scientific knowledge. So all I'm doing is sort of shifting that and showing you what I understand. This is the second time that I'm speaking to you. We talked to you about a month ago. So some of this is a little different. Some of it may be an update. We know a little bit more than we did a month ago. And I tried to get what is published, reliable information and give you the most up-to-date. I realize that as I'm speaking, new things are coming out. And so I'll defer to you all who have Google in front of you to be able to help me with that. With that said, I'll jump right in. So the first thing that I'm going to start with is something from The Lancet. So if you're looking at medical journals, there are a variety that are pretty well known, and I think most of the articles that I pulled from today are from those journals. This was an op-ed that came out of The Lancet, and so this was really the impetus for trying to address some of this. So this came out a few days ago, and it says, "Fighting Panic with Information." So on February 15th, the World Health Director General said, we're not just fighting an epidemic, we're fighting an infodemic. And I think that's true. And so one of the things that I'd like to provide you then with is information. The ease with which inaccuracies and conspiracies can be repeated puts public health at constant disadvantage. And so the only way to really combat this is to provide verified information. And so I would tell you that at every level of health, whether it's at your local clinic all the way up through the national level to the World Health Organization, is all of those groups are trying to provide the most accurate, up-to-date information. And my hope is to give you a similar scenario here. This is the most up-to-date, at least as it was about a half an hour ago when I was on the California Department of Health website. So it's dated as of March 8th to give you some sense of the number of cases that we have in California. And I won't read them to you, but to give you this sort of breakdown of what we understand. So in total, in a state of close to 40 million, we have 114 cases. And so just to give you some perspective. Now, there are some, as we'll probably get into later, there are some issues with what we understand, who's been tested, things around the data, how these things are being transmitted from person to person. But it's worth understanding that number in a state of about 30 to 40 million. One thing that I'd like to point out is that I've been hearing from people, well, California is the hotbed. California is the place where this is going on. That may be true. Part of the issue is understanding who was ahead of, who was testing, who was first in testing, who's the first in reporting. So now every state in the country is able to test. What's worth understanding is some people are coming on, or some states are coming online later than others. So California has been doing this for a while. New York started testing, a few weeks ago. So you'll start to, what you can anticipate is that we will see more positive tests from more places. Does that mean California has more than other places? Well, it has to do with the denominator, right? We're not entirely sure because not everybody has been testing in the same place. So it's worth understanding some of the data that we know about. The next thing is, as I was preparing for this, I was looking at some of our groups that have been recognized as potential high-risk groups. And so one of those is people with lung disease, and specifically we've got a number of questions around asthma. So I was looking at a nonprofit group, the Asthma and Allergy Foundation. They had a nice slide that I thought helped with trying to communicate some of the risk as we know it, particularly from a public health standpoint. Because as you can imagine, public health, although they're dealing with coronavirus, they're still dealing with the flu, the measles, you name it, a number of things that are still evolving. And so I think this is a nice infographic. This is for the United States as of 3/3, as of March 3rd. So, we've had additional cases and additional deaths. But it's worth understanding that at least in the last year, we've had about 45 million cases of flu and about 46,000 deaths. And so everything that we're doing for coronavirus in terms of hand washing, self-isolation, all the rest, also applies to flu. And I'll tell you that in looking at the history of some of the other infectious pandemics and epidemics in the last 2 decades, one of the things that we saw was as we were addressing the pandemic, we saw a number of other infectious diseases go down because of all the hygiene and all the practices that went on. So I'm going to switch gears a little bit and just give you some of the backbone of how health works and prevention works, particularly in the workplace. And so for those of you who aren't familiar with this comes from the Centers for Disease Control. It's this image does. This concept is relatively old, and it's something called the hierarchy of controls. The reason that I point this out is that for people who work in safety, they're well versed in this. But for people who don't work in safety, this is sometimes a new concept. And so there are a few things to recognize when we have hazards in a workplace. So things to understand or to assume with the hierarchy of controls is one, that someone is generating this, generally the employer. This is classically used in, let's say, like a toxic environment. Somebody's grinding lead or creating some sort of hazard. So there's an ability to create that, which means there's an ability to control that. It's a little bit different when you have something like an infectious disease, which is not something that that's being specifically created or has a particular control. But what I want to walk you through is how the teams that I mentioned earlier are looking at this in terms of trying to control this in an occupational setting. So we talked about the first piece, which is to eliminate it, which really works in more of a sort of toxic environment. But you can imagine there are things that we could do, like say, well, there are certain groups that are high risk that we're probably not going to bring on site, and you saw that happen. One thing that I should orient you to, so you have this upside down pyramid, and then on the left-hand side, you see most effective to least effective. So most effective is just removing that. The substitution piece really has to do with something when we're creating a hazard of some sort. Maybe we can take something known to be hazardous and swap it out. Doesn't really apply in this scenario, but I thought I'd address it. The third is engineering controls. This is something that's used particularly in a healthcare setting. So when when we have a nurse who has to go in and treat a patient or help care for a patient who has a communicable disease, things are put in place like putting somebody in a room that has the ability to remove that air at a constant rate. Not something that we do so much in the non-healthcare setting, but it's something to realize. Then you put in something like administrative controls. In a place like this, things like, barring access, let's say, for certain groups to come on, or if there's a high-risk group, singling that group out and saying, well, this is a group that might be able to cause some threat, and so we would contain it in that way. And then the last one I'll point out is that what is in PPE, personal protective equipment. This is usually for people who are not in the safety realm, the first thing that someone goes to. And I think what has been a bit confusing, at least from what I've seen in the media, is that this seems like the first thing that we should grab. I want to put a mask on, I want to put a suit on, I want to do something, which is natural human behavior. When you're faced with risk, there's something you want to respond or do something. But I'll tell you, from the numerous studies that are done looking at personal protective equipment, it generally tends to be the least effective. And it really has to do not so much with the equipment. Generally, the equipment's designed fairly well. It has to do with the human. Humans can put things on and do things for limited periods of time, and then they start, well, the thing bothers me, so I'm going to pull it off my face. Or it does something that it fails, and I don't recognize that it fails. And so the reason I bring that up, and I'm sure we'll get questions on this later, is, well, why isn't the health department telling everybody to wear a mask, even though I see somebody overseas wearing a mask? And it's because we know that human behavior is such that generally when these things like PPE are used in the workplace, which is where they were initially designed for, they're used for very limited amounts of time, and there's a lot of rules around it. Somebody's going to put it on, somebody's going to take it off. There's someone else monitoring them putting on and taking it off. A little bit different when you then extrapolate this or push this out to the general population. So another op-ed that came out, this was in the New England Journal of Medicine, that says, another decade, another coronavirus. This is from a professor of microbiology and a physician who specializes in infectious disease. The reason that I point this out is that it's another key thought that's going on in the public health infectious disease realm, which is we know that coronaviruses exist. Some of us have had some version of one in our lifetime. But there's trying to understand the proportional impact of what an actual infection does, and then all the things that we're seeing as a downplay. It has nothing to do specifically with the infection. And so Dr. Perlman says that in the last SARS epidemic, fear played a major role in economic and social consequences. I think we can all agree that we're seeing that as we speak. And what's interesting is we know much more now about how transmission and things worked with that particular coronavirus than we did back then. And he says public health measures, which were critical in controlling SARS and MERS, will likely be just as important, or institution of similar measures will help. And so that is what is coming from your infectious disease experts within the United States and being published in these well-known journals. The next thing that I'd like to talk about is something that has come up, and I think one of the things that we do in medicine when we're looking at these journals is we critique these journals, right? There's never a journal that we say, this is the perfect journal article, or there's no problems with it, and so forth. And so the next few that I'm going to take you to is going through that. So normally when we do this, we get a bunch of people around a table, and we sit there for an hour on one journal article. I'm not going to put you through that right now. But when we do that, we say, this was how this study was done. These were the pros of this journal. These were the cons of this journal. And so for the next few that I have for you, what I want to do is point some of that out. Because what I've seen is some of these journals then get repeated in the media. And I'll tell you, from the limited amount of media that I've seen, there hasn't been a single report that I've heard that has gotten it exactly right. Some of them have at least some part of it wrong. And I don't blame the reporter. They're not scientists, but it's worth understanding. So to give you some just orientation to the slide, this is the article that came out from New England Journal. And it reports somebody who has an asymptomatic transmission of coronavirus, which sounds pretty scary. This was early February that it was published, and this is still sort of being promulgated. And so the story was that a person came from China, flew into a business meeting, met a couple other people, they shook some hands, and then she flew back. At that time, the people who wrote the journal article said, well, she was asymptomatic, so this is an example of asymptomatic transmission. There's another journal article very similar. This was a New England Journal, but there's another one very similar in JAMA, Journal of American Medical Association. So what's the one thing that would probably be pretty important that you would need to know about that asymptomatic person if you're going to publish this? or that they had symptoms, right? So the one thing that the journal notes was that they didn't ask her if she had symptoms. Nobody talked to this person. It turned out that the public health department talked to this person. So the way, and so we'll see whether or not this gets a correction or a retraction. But one of the things that was noted was that there was no time to talk to this person. So we're going to publish this so we can so we can alert a number of people. Well, it turns out that when the public health department went and contacted her, she said, no, actually, I did have symptoms. So it makes this asymptomatic transmission journal article and the impacts of it a bit different. It doesn't mean there can't be any asymptomatic transmission. No, there probably is. When we know the things that we understand about other viruses is that we know that there's something called viral shedding. We know that there are people who may not recognize their symptoms and can pass it on. But I think it's worth understanding some of the pros and cons with the way these studies are done. So they didn't speak to her before they published the paper. It's probably worth understanding in that. There's a few others that exist out there, similar critiques. This is a nice review that's both in JAMA and from the Chinese Centers for Disease Control. It's a very busy slide, so I'm not going to walk you all through it. The things to point out here are that the understanding who the groups were that had this tended to be more adults at the time. If you look at some of the groups, things like laborers and farm workers had pretty high rates of confirmed cases. Nobody has really explained why that is, but understanding how people live and work is probably worth getting into. Do people who work as farmers and laborers in China have different living situations than people in the United States? Probably. Do people who live communally have different exposures? Probably. This is what has been, this was 70,000 cases that were suspected and 40,000 that were confirmed. Some other things, and this is what is sort of driving our understanding then, is if you look at these large populations, you can start to understand what we think are risks. From what you're starting to see now, and public health has been emphasizing this, is that we think there are probably particular risk groups that are higher risk for contracting and having significant illness than other risk groups. We probably won't know that for at least a year or 2 years, and that has to do with the way this information is collected and analyzed. But at first look, people who have these comorbid conditions, if you add them all up, are a much higher risk group than people who aren't. Now, that doesn't mean to say that there aren't people who have no risk factors who are also at risk. We know that that's true. But if you're a public health department and you have to put resources into protecting the population, who is it you're going to be most worried about to put your finite resources into? It's going to be those populations that are at higher risk. One of the things that's interesting that they point out is the majority of the cases, over 80% of them, were considered in the mild category. The reason I bring this up is that sometimes we can get pretty riled up with the way things are being portrayed to us. But it's probably worth understanding that the overwhelming majority of these cases are mild. Now, that from a public health standpoint, there's a different calculation there. If there's even a few percentage that are really critically ill, that can overwhelm a hospital system, and we're seeing that. It's a different calculation when you're running a health department and trying to understand how many hospital beds, how many ICUs, how many nurses. Are we going to be able to take care of all these people and still take care of all the regular people that come in with heart attacks and strokes and all the rest? And so that's one of the big concerns. This is from the World Health Organization, and this is how the pandemic plan that is used here at the lab has been formulated. I would tell you that I think right now we're in phase 4, sustained human-to-human transmission. We're anticipating phases 5 and 6, where we have widespread transmission. The pandemic plan that we have written and rewritten and have updated all addresses this similar to how the World Health addresses this. And so questions that I'm sure we'll get into is what do we do if? What do we do if one person has it or 10 people have it or a lab has it and so forth? That's all driven by the way that the public health organizations think about this, because not surprisingly, this isn't the first time, right? We worry about this with flu, we worry about it with the previous coronaviruses, and we'll worry about it again when the next pandemic comes through. I wanted to give some idea, because we get a lot of the questions around this about what is it that this actually means. What's the difference between an infection, a case, testing positive, and so forth. And the reason I bring this up is because there's a difference between all infections, confirmed cases, and then severe, and then confirmed deaths. So what you have here in this pyramid is that piece, and so it's not to scale. And so I would tell you that the confirmed deaths are actually much smaller, right? This isn't to scale, but I couldn't get the PowerPoint to get some of the fonts right. And then what you have over here on time is looking at, for the majority of these infections, they will occur early and then resolve, and then we'll have a lot more that will be later and much more severe. The reason I bring this up is that we are seeing some of these definitions change. And so as we see definitions change, the numbers will change. Generally, these are initially overestimated, right? We estimate them based on the number of tests that we have. The tests are finite. And so when we start looking at, and this is really just a simple division, right? A numerator divided by a denominator. So if we were to say, well, how many people died? How many confirmed deaths do we have? So that's on the top, right? And the bottom is, well, how many people had this? Well, right now we have a really small number in how many people we had this, because we only have so many tests that we can do. You're seeing that we're going to start, that's going to expand, because not only are you going to have public health tests, but you're going to have commercial labs running that. So that bottom number is going to get much, much, much bigger. And this happens with every sort of pandemic, is that initially these things are overestimated. And that they're overestimated both because of the way these tests are done, but they're also overestimated to be conservative when something first comes out. So that will take me to the next slide when we start comparing this to some of the other things that we know. And I added to this slide something which is the exposed. And it's worth understanding that all of us probably have had some version of exposure, whether it's to this or something else, depending on what disease you had. We know that we had one confirmed case in Berkeley that came out, I think, last week or so, right? And that person largely stayed home for their self-isolation, but not for the entire time, right? So if you in Berkeley, there's a potential that you have an exposure. That's not the same as having an infection or having a severe infection or having a death. And so when you hear this, it's worth understanding that there's a difference, and that public health epidemiologists, the docs, we all understand that. So it's worth giving some of that to you. I'm down to my last few slides, but one of the things I wanted to talk about was the comparison of some of these viruses to what is already known. So this, I think, was published in the beginning of February. So I'll orient you to what a case fatality rate is. That's just what I was talking about, right? We just took a numerator and divided by a denominator. We said the number of deaths by the number of tests, the confirmed cases that we had. Well, that confirmed case is going to get much bigger. And so at that time, we said, well, it was about 3%. That's probably going to go down. I don't know if it's going to go down much, but it will go down just based on the number of tests that we have, assuming that we don't see much higher rates in deaths. Then you have something over there which is pronounced R0, or it has to do with the ability for somebody to infect another person. So there's sort of three ways that you can look at this. You have somebody who has an infection. You have somebody who doesn't have the infection, is presumably not immune to it. They can infect one or a number of people, right? So the average number of people that you can that initial person can infect. So that would give you something greater than one. They can infect more than one person, or they don't infect more than one person. So let's say less than one. So the important part to realize here is that for at least what we are now calling COVID, we've got a pretty wide range, 1.4 to 5.5. And that has to do with, we don't quite know, right? We haven't been able to go through and do all these numbers. And so there's two pieces to look at. Is if you start to go through and say, well, what's the case fatality rate and how effective is this thing? It starts to give you a place to put this in your level of, I wouldn't say level of worry, but at least to give you some ideas. And so if you look at now SARS, we had a 10% case fatality rate. People are pretty familiar, or that's fairly confident, with the ability to spread to, on average, about 2 to 5 people. MERS, a lot higher, right? We have a lot higher case fatality rate, but a little bit harder to transmit. And then you go through and see avian flu. Some of these things sound a bit esoteric, but measles, this is one that public health worries about all the time, right? Measles is pretty easy to transmit. It doesn't kill a lot of people, but it causes a lot of non-death, but a lot of morbidity, meaning, it may not kill you, but it's going to put you in the hospital. It could put you in the hospital for a while. Ebola is another one that I think is pretty high, would be pretty concerning because of its fatality rate. And then we have HIV and smallpox. So I want to give you some idea of how to compare some of these things. One of the questions that comes up is, well, what about this symptomatic person? So if we were to group people, and this is what the literature is saying, is if we were to group people into asymptomatic and symptomatic, can an asymptomatic person transmit? Yeah, probably. Can they do it as effectively as somebody who's symptomatic? No, right? Then it has to do with, are they sneezing? Are they leaving particles? Are there things that can be transmitted? And I think as we have more science and more time, we'll see, we'll see these two groups. And that's why you see public health really focusing on the symptomatic transmission. Is it possible to do this other thing? Sure, it's possible. And what we know about all the other viruses is that we can have some asymptomatic shedding that can be transmitted. But generally, they're just not as effective as somebody who's got what I would call frank or pretty obvious symptoms from a non-medical perspective. Just tends to be able to transmit higher. Question that comes up a lot, and I think this will be one of the last sort of scientific ones, but this is one that comes up a lot, is 14 days enough? Where did they come up with this 14 days? And should it be 15 days or 21 days or 38 days or pick some number? And so I wanted to give, so this came from the New England Journal, and it was looking at early transmission dynamics. So what that means is somebody found out that they had coronavirus, and somebody else went back and asked them, hey, when did you think that you had symptoms? Now, I don't know about you, but it's hard for me to remember what I did yesterday or 7 days ago or 14 days ago. And that's well understood in the literature. There's this thing called recall, and it's hard to remember what this is. So one of the things that they noted was that on average, so I think we have a lot of scientific folks in here, so we understand the pros and cons with an average, but on average, it was about 5 days. Now, most of the other literature has it somewhere in that range, somewhere between 2 to 4 days, 4 to 6 days. 95% of these transmissions or people were symptomatic within 12 days, right? And then there's all this sort of tailing off, well, maybe it was 21 days. But understanding the pros and cons of the way these studies are done gives you a sense of, 14 days should be sufficient for 95%. And then you say, well, what about that other 5%? I say, is it possible? Sure. Does the data support it? Maybe. I don't know that I can definitively or ever say absolutely 14 days, it's not 14.1 days. But this is where this data comes from. And this is why the CDC and other groups are relying on it. If it turns out that this turns out to be skewed and it actually is 21 days or 28 days, then I think we'll see that bar move. But that's where that 14-day comes from, and that's why it has been relied on. Masks. So this isn't a scientific study, but it's one of the best illustrations that I've seen on masks. I talked to you earlier about the pros, cons, strengths of personal protective equipment. You see sort of two recommendations that sort of can get intermixed. And so to be clear, someone who is working around someone who has this, so you're a healthcare provider working with someone who you suspect or now is known to have this, these things tend to be pretty protective, particularly because they're in an area where ideally the room air is being taken out, all of that exposure is trying to be minimized. But something else you see is that, well, wait a minute, now I am not known to be exposed, I'm just in the general public, why wouldn't I wear one of these things? And so this is, that's a question that we get a lot. So I thought I would try and orient you to this. So what you have over here is a diameter of human hair. And then you have what can be filtered out by what would be a common sort of surgical mask that you see, and then what you can see filtered out by an N95. And then all these little red dots are what the actual diameter is of this coronavirus. And so one of the things to understand is when we have a healthcare worker where we're putting all these controls into place, we understand there's still a risk there. It's not 100%, but we try and put all these other controls in. When we remove some of those controls and just give somebody a mask, there's potential for increasing the risk of these things, because not only does it not filter, but there's a bunch of human dynamics that go on. Well, now I'm going to start touching my face. I'm going to cough into this thing. Maybe I get a big hole in it. Maybe it doesn't fit well, and I've got a millimeter. So you can imagine a millimeter versus a micron when there's a space between these two things. So for all those reasons, why public health is saying, well, there's not any evidence that this can protect you. That I don't know that I could tell you it's going to cause. I haven't seen anything that says it causes an increased risk, but there's concern about whether or not it provides adequate protection in the general public, different than what occurs in a healthcare setting, or even somebody who's at home. So we have a number of people who are home with another person who is symptomatic. There's some thought that this provides protection for those people. I'm going to end soon and just get to questions, but these last two slides that I have are the same ones that I had from the previous. And the reason I put them in is just as a reminder in terms of what do we do for work. And I mentioned the entire teams that work around this. So I probably should, there's EHS, we have facilities, a variety of people who are around that we have that we can rely on. And so there's the EPA, and you probably see this in the FAQs. The EPA put out, well, we get questions of what kind of cleaner should I use? And so the EPA put out a list of those. And so if you go like to the Lysol website, I'm not endorsing Lysol, I'm just saying as an example. If you go to this website, you can see these are the products that meet the EPA criteria. And the EPA now has that online. And we have that in our FAQs so that you can go to your eBuy and purchase these. And so it's all the same things that we would do for any regular flu, infection control, things like that. And then health services. So I am one of a bunch of people, all these teams that I mentioned to you. Health services is available. The things that I would tell you is we're not a replacement for your primary health provider. We're not doing any testing here. We would defer that to your primary health provider. But let's say you can't get a hold of your primary health provider. You have a question. You want to talk to somebody. We're here for that. I would ask you to be patient with us. As you can imagine, we're getting a lot of calls. And I would ask that for the other groups that are working for this. If there are, we had a lot of questions, and we can probably get into them about, well, what about my employee? And so we will direct you and say, this is a health question. I can answer this piece. But some of this is really a supervisor and employee question. And so we put FAQs and work with HR on those things. If you're sick, stay home, right? There are a variety of people who are sick otherwise had nothing to do with this. I had a GI illness. I was having vomiting and so forth. Well, let's have you stay home. When you're better, come back and see us or let us know. These are all the same resources. The big one that I would point out to you is employee assistance. I think that has probably been the biggest, I would say, burden to our employees that I've seen here because we don't have any infection, right? And so I advocated for this talk to really be all about employee assistance and some of the anxiety that goes around this. Because I'm not an expert, so I was advocating for somebody else for an expert to come talk to you on that. But my hope is at least I provided you some information on some of the topics that are coming out and the research that's out there. I will stop. We're about halfway through, so I anticipate we'll get lots of questions. I have a few backup slides that I anticipate will probably address some of the questions. So I'll stop and see if there are any questions. Sure, we have one question here in the theater.
So I've heard reports that people in China were getting sick again after their symptoms had cleared, like a month later. Do you know anything about that?
So the reports, I've heard that. There's a couple of interpretations that I've seen. At least in the literature, I haven't seen a second sickness. What has been described in the literature, that is a second positive test. And so that's different than a second infection. And the reason why is we know that some people will have viral shedding for some period of time, and we're still trying to understand what that actually looks like. I haven't seen any literature that says somebody had coronavirus, was treated for it, completely recovered, and then had a second infection. What I have seen is somebody had coronavirus, we thought they were clear of it, we go and test them, and they have a second positive test, which, to be honest with you, is not very surprising for two reasons. One is we understand the biology that people can have continuous shedding. The other is that these tests are pretty sensitive. The ones that are out now can pick up strands of DNA. And so it's not totally surprising. We've seen that not just on this sort of secondary piece, but somebody gets tested on day one from their right nostril, nothing shows up. They get tested on day two, and something shows up on the left nostril, and it has to do with the way we think the test was conducted. Was it the same way? Were they having viral shedding? Was it the same? Did it have all the same characteristics? And even if it was done all the same, just given the temporal nature of it, people can have episodic viral shedding.
We've got almost 250 people online, so they've got a couple questions coming here. One on your knowledge of the modes of transmission, and is this truly airborne?
Well, so it is airborne. So that there's a question that had come up. So this will gross you guys out a little bit. This is a picture that comes from the CDC. So this is a guy sneezing, and so what the idea is that if someone were to sneeze and you're in some radius, and so the number that has been is 6 feet. Can I get this? Yeah, you can. You can be transmitted that way. That's the way this is understood. So yes, it is airborne. Yes, it can be transmitted that way. And so all the reasons for, if we go back to our hierarchy of controls, if you're in that symptomatic stage, we're going to try and just remove you, right? We don't want people to have this exposure. There are other things that are still being worked out in terms of, well, if it's on a surface for a period of time, can it stay and how long can it stay? Well, that is probably going to get worked out in some period of time. In the meantime, we know that we have effective ways of cleaning. One of the things that I'll point out is the way that it's recommended to clean with the label is how I would tell you to do it. And the reason I bring this up is when we had Ebola, there was some thought that, well, if there was some Ebola and I use chlorine and I use ammonia, well, if I put them together, they work really well, and it's really going to kill Ebola. And then we had people having issues with lung problems. And so what I would tell you is just use it the way the label describes using it. Somebody has put some thought into how that works. You don't have to combine it. It's not. The other things I would tell you, it's not radioactive. There have been questions about that. It doesn't pass through walls, right? So I know some people are sort of smirking, but I'll just tell you, in people that when we talk to patients, these are questions that come up. This transmits, as we understand it, like just about any other upper respiratory infection, no different than other coronaviruses, flu. There may be some different physics and dynamic around the science of the physics and the dynamics of it. I would tell you from a healthcare perspective, we treat this just like we have a long list of things that we consider aerosols. Tuberculosis is one of them. Measles is another, and we treat it all the same. Let's see. Okay, you got one here. Sure.
Can you tell us something about the status of the research on the virus? I mean, vaccines and laboratories. I'm sure there are plenty of activity, but no, I don't read anything about that. What's the status?
Yeah, that's a good question. Do I know anything about the status? It sounded like on the basic research and ideally the vaccine. At least as I was scouring yesterday and this morning, most of what I've seen has been not in the literature. It's been, for example, from the CDC. So I wouldn't be able to give you the characteristics of when's the vaccine, what are the different parts of the virus that are being addressed at this point. I haven't been able to dig deeply enough. I'm sure it's out there. Now, as you understand, there are ways. There's a sort of long-standing way of how vaccines are developed. I don't anticipate that this will be any different, which means there will be some testing time, some basic research time, some testing time that will go into this, and we'll see whether or not by the time the vaccine comes online, we're still having human-to-human transmission. But I don't have any specifics that I could give you.
I just had a question. Is Berkeley Lab a point of dispensing site? And do we have a pod program in place?
So that's a good question. So what you are referring to is something in the public health realm where we have very specific definitions for places that may have equipment, medications, and so forth. And so if you look up things like the Strategic National Stockpile, which is something that's described through the CDC, there are various points throughout the Bay Area that have that. We are not one of them, so we don't dispense antibiotics or antivirals or anything outside of the lab.
People are asking about, has the virus mutated, as they've heard that, and also telecommuting, and people who have got some sort of immunocompressed system, should they be coming to a place like this?
Sure. Okay. So the mutation piece, there's two. I think there's probably two ways to look at it. The question is, or one way to look at it is, has it mutated from when it where it first came? And the answer to that is yes, and I think that's been described in some of the different genome. The second question is, has it mutated from January 1st to January 31st? There are a number of people who are looking at that. I haven't seen any publications around that. There are sort of expected mutations that occur. I haven't seen anything that describes a mutation such that it changes the virulence, how bad the infection is. So I haven't seen that it says it's mutated such that it's much worse, or it's mutated so that it's not much worse. We anticipate that just based on the biology. But I haven't seen anything that has said this is now mutated, that we are going to take a different approach that we have. The second question was on telecommute. My suspicion is the question gets around, should I or should I not telecommute? And so I think I would back up and answer that with sort of two things in mind. The first group that we think about is anybody who, and this is where most of the effort has gone into from the public health perspective, is somebody who is symptomatic or is in some other way has met a certain CDC criteria definition, which, by the way, is changing. So in that group, we would say, yep, you would do whatever it is that the CDC, your public health department, your primary provider is recommending that you do. So that is in the symptomatic realm, and really that's in an illness, right? And so in the occupational health realm, this is now more in the HR piece, but there's entire policies on how to deal with that, the illness piece. The second question is, all right, well, I actually don't fit into any of those categories, but I am worried about this. I have one of the diseases that have been, I have a chronic immune disease, or I've got a lung disease, or my family member has a chronic immune disease or a lung disease. There's nothing out from the public health department at this point that says people shouldn't be with that, with those health conditions shouldn't be in the general community setting. Under that is included in work. Now that doesn't mean that you can't take administrative steps to say, well, we're going to limit the amount of access and so forth. Gets a little dicey, less on the medical side, but more on the HR side, is to say who can and can't come into work. From a scientific medical perspective, there's nothing at this point saying, yeah, I don't think you should come in at this point. Given all that, the way that we've been working on this in the teams is to say, look, a lot of this, since there's not a health or medical piece that I'm able to point to for you, is really a decision between you and your supervisor. If you have work that your supervisor can have you work from home and you guys work it out, I have nothing I have no input at that point. If you don't, that's another sort of supervisor piece. This is all on the asymptomatic, no identified risk. When we start to ramp up and say, well, wait a minute, now this person has an identified risk, we'll have to make some different calculations. And I think that will be based on, the big piece will be based on that person's individual personal health piece. And we can help with some guidance on that. But it really is going to rely on the specific situation and the specific person.
Okay, another one from online. Somebody's asking about the differences of the way different countries are responding to this virus and why some countries are so successful and others aren't, and they're asking for your thoughts on that.
Yeah, it's interesting. So there is some literature that addresses that. I think there are a variety of different thoughts that are out there. Probably the clearest is has to do with the way the different governments are organized or respond. Clearly, some governments have a much stronger ability to limit movement of nearly 1 billion people than others do. And that just has to do with the way these places are set up. I'm not saying that the U.S. couldn't do that or could do it, but it's worth understanding that the fundamental way that these places are set up is different. And so that then not only drives the way the government's set up, but the way public health responds. I would tell you that in general, the science between all the countries is generally the same. It's generally pretty well understood in terms of prevention, limiting access, and so forth. But a lot of this has to do with the way the politics and the way a government is set up. And so I think we'll see, and we've seen this in the past, there are governments who have pretty limited resources that do pretty well with public health response. And it's because they've had a fair amount of public health infrastructure built in. We saw that with Ebola. There are a number of countries in Africa who have pretty limited infrastructure, and they did pretty well with containing it. my sense is that with the right resources and the right setup, you'll see different responses. South Korea had a scenario where they had a group that was not adhering to public health advice, right? That's a bit different when you have sort of at least as it was described, as sort of willful non-compliance, as opposed to people who are complying. I'll tell you that most of the questions of people who are, we don't have a case here, but I'll anticipate that we will have a case here. Most of the people who came anywhere near that called us, not because they were worried about having the virus, but they were worried about what their supervisor, their coworker, what it was going to be like for them to come back to work. And so we were able to confidentially talk with them and go through, I've talked to health departments and I said, is this person anywhere near on your radar? Do they meet X and Y criteria? And they say no. And so we're able to provide some cover for that to say, look, this person may have met some criteria, but no longer do. They're able to come back to work and don't cause any potential threat to any coworkers. I'll stop there because I'll just keep rambling.
Okay, online one more.
All right.
So we have a lot of visitors here at the site, and if we see a visitor here who's coughing, sneezing, what are we supposed to be doing about that?
So I'd back up and say I wouldn't limit it to visitors. I would limit it to anybody you see on site. I can't tell the difference, and I don't tell the difference between a visitor, a career employee, a postdoc. We have a whole bunch of different categories that we put people in terms of their pay status and employment. I think I would back up and say, if you are concerned, and we have this in our FAQs, you see somebody coughing, sneezing, and so forth, I'd like to limit the sort of medical inquiries that go on. At the same time, this is we're in a heightened sense. There's concern for worker health and safety. So we put that back onto the supervisor and say, well, let your supervisor know and let HR know. We can obviously help give them some advice around this. But we have seen some scenarios, and I'd like to stay away from it, where that we start to get down to medical inquiries and who we're categorizing. It doesn't take long to go down a slippery slope of trying to point people out for a variety of things, whether it's their origin or some other thing. And so I'd like to focus on risk, right? What is the risk? If somebody has no risk, there's probably there's not a whole lot that I would say is something that we would address. Now, let's say that somebody is symptomatic and we identify you really have no risk for coronavirus at this point anyway, but you really sound like you have the flu. I don't think that person should be here, right? In terms of just a population level, not me, Timur, personally, I'm talking about in sort of population level. And that's consistent with CDC guidelines, right? If you're ill, stay home, work with your supervisor, see if you can work from home. If you can't, we have their entire system set up to support you while you're out ill. That is, I would say, probably the most prudent way to be able to continue the work that you do and keep your coworkers safe.
So there was a bar chart that compared the flu to COVID-19, and maybe on the face of it it's accurate, but it felt to me like the message it was sending was a little misleading because COVID-19 is just getting started. We're just starting rolling here in the U.S. and it's not clear what's going to happen, right? It could become worse than the flu for all we know. Maybe it becomes a seasonal thing with a much higher death rate.
Yeah, I mean that's all true. I couldn't tell you what is. I couldn't tell you how it's going to go. That's all true. I think the point of the bar chart is to give you some sense of risk at this point. Part of what you're describing, the reason why we know so much about the flu is because we've had some time to go through that, and we've had these pretty elaborate systems that have followed the flu over decades. So I'm sorry if it's misleading. I think I like the way that it presents the level of risk as we understand it at this time. What's the level of risk in a month, in a year, in 2 months? I don't know. I couldn't tell you. But it is true and accurate as to what we understand as of today.
What's the lab doing? Hand sanitizer is getting hard to come by, and those ever popular wipes. What are we doing? Is there any way we can make sure that we have a supply here? And if not, what's the substitute?
That's two good questions. Let's see. So hand sanitizer, I'll have to defer a little bit on our procurement folks, but we have a list of hand sanitizer. We've purchased more. You'll see them more in the cafeteria and the coffee shop, in the badging area, sort of the high traffic areas. I would have to ask procurement, or I would defer to procurement as to what they're doing in terms of getting more and so forth. In terms of substitutes, I don't think I could give you any recipes. I don't have a secret recipe for hand sanitizer. And so at this point, the one secret I would tell you is I like soap and water, right? Soap and water is as or more effective than hand sanitizer. And from what I'm told, there's no shortage on soap or water. And so what I would tell you is even when we use hand sanitizer, we only use that every so often, right? So in a healthcare setting, when we go in and we see somebody who may have a contagious disease of some sort, we use it about every 3 times, give or take, right? And then we say you really need to wash your hands. And so hand sanitizer is good. I like it. I really like soap and water. And so I would tell you if you don't have hand sanitizer, soap and water.
I have a weather question for you. I think this may be the last one here. Is it going to go away when it starts heating up?
Oh, it's a good question. I don't know that so I couldn't tell you for sure. Although we do know that there's a seasonality to a number of these things. That's been somewhat addressed, I think, at least in the media piece, and we have seen that. We see that generally with the flu in regards to its seasonality piece. So I couldn't tell you for sure. The weather is one component of transmissibility, or the environment is one component. I would tell you I don't know. I couldn't give you any data to back that up. That's something that's sort of anticipated, but I don't have any data to back that up.
I'd like to thank Dr. Durrani for his time this afternoon. And I would also want to advise everyone that we'll be sending out additional guidance this afternoon to talk about travel, conference attendance, visitors, telecommuting. And I want to emphasize, telecommuting is an option that everyone has. Work with your supervisors, and we'll be sending out some clarifying guidance about all of these questions this afternoon. We'll continue to have seminars like this, and I'd like to thank Timur for his time. Thank you, Timur. Appreciate it. Thank you.